Stephen, it's an enormous pleasure that you and Ian and Alan have put together this programme, and I wondered if you would explain why you've shaped it this way.
Well, thank you. I think the underpinning argument that we all had was to try and take attendees through an entire spectrum of diagnosis and treatment of the spectrum of venous disease you get from deep and superficial system. You
see them all as part, don't you? You don't really separate the superficial and deep as much as perhaps we did a year or so ago?
No, I think that's right. I think that's one of the things that we've really picked up on in starting to be more observant of what's going on in the deep system, particularly outflow obstruction, that we may have missed in the past how closely interrelated the two systems are, and that you can't really separate them out. You have to look at the whole and then move a patient through a treatment pathway that takes account of what's happening in each individual component.
So what's happening in the deep space can affect results of the superficial?
No, absolutely, and I think now that we're starting to recognise the outflow obstruction component for recurrent veins, for example, or leg swelling or PTS, we're starting to see more how we have to look at each individual but get each of those right before we're going to get the patient right at the end of that treatment plan.
So you're seeing ultrasound the centre of the beginning of investigation. Can you explain why that is?
Well, I think ultrasound technology has moved on enormously in the last few years, and that gives us more options. If you start to incorporate B mode and contrast enhanced scanning, you get a lot more out of imaging than we.
And what about the function? Do you get something of the function with state-of-the-art imaging?
I think that's something we've still got to research properly. I think flow is poorly understood on the venous side as a measure of or predictor of success. That's somewhere where we're going, but I think
you can
that's
have the patients erect at least.
We would hope so, yes. It's better than...
Well, you can't with all
CTV.
The modalities, can you?
Absolutely, yeah.
Where are we with the new venous valves, and when will they be put in? What benefit would they do a patient, do you think?
Well, I think valves have always been, still are the final frontier. We kind of have moved on in a lot of other aspects of treating venous disease. We could argue that nowadays with any of the techniques we choose for superficial vein treatment, we're getting exceptional results across the board compared to what we may have achieved in the past. Where we are with valves is all of the techniques are still flawed. You may have an excellent surgical technique in one person's hands, but it's not transferable. You may have valves that fail.
That's a shortcoming of a technique.
Yeah.
You know, if you've got to have somebody superhuman to be able to do it, it's not quite the best way, is it?
Well, not in the long run, certainly not from what I'm going to see. So I think valves are exciting. Where are we going to go with those? My personal view is it's going to be biologically implantable valves at some point in time. There's a lot of research going into that. I think we'll see that overcome some of the mechanical difficulties of valves that have been tried so far. We've had huge advances in stenting, and we're starting to see more companies into that fray, which indicates that there's an enthusiasm for treating this now, and we need to harness that enthusiasm in the correct way, and it's beholden upon us as groups like Charing Cross to steer things in the right way, and I think that's what we're trying to achieve here.
So it's all very well for the audience to be listened to. On the one hand, we may be able to use a venous stent, which would then open the vessel, and another time put in a venous valve. First thought, the one is opposed to the other. The one is trying to open a channel, but if you open it, it won't have a valve and it will be incompetent. So perhaps you could explain in what situation you would wish to have a stent, and assuming that valves will, I'm sure they will, eventually be very successful, what would be the ideal situation you want to use those? Separate the two groups.
So I think there are two bits to this. The first one is if you never have a good tool for something, you tend to ignore it. So for years we had no good way of opening vessels up, so we ignored it for a long time. And now that we've understood that we can open vessels and we can get good results, which have been demonstrated by a lot of the studies being presented, we're looking to open vessels up. Now for me that is...
For the ones where there has been an occlusion, a thrombus, and the walls are stiff or...
Yes,
what?
Exactly. And I think that's really inguinal ligament and above. And what we know from the anatomy is that above the inguinal ligament, there are very few valves in the human body. So it is all about obstruction.
It's all about obstruction. That's a key point for the audience, isn't it?
Yes.
It's obstruction above the inguinal ligaments, but it's not quite the same below.
No.
Yeah.
So below the inguinal ligament in the femoral vein, we have a much bigger challenge, and that challenge is getting the balance right between relieving obstruction, which you may do in the beginning, and then having to do something about the reflux that develops afterwards. And what we have to understand is how much that reflux plays a part in persistent symptoms once the obstruction has been dealt with. The trouble for us is that the valve side of things is still the most difficult, and that leaves us with a small cohort of patients who don't have a good solution at the moment, and that's our challenge, to get that question answered.
So clear. So you practice at St Thomas's Hospital, the Hospital of Cocket, and he would want to know if the perforating veins are still important.
Well, I think it's a very interesting question, that, and I think to some extent, I think we overestimated the role of perforators by missing the role of obstruction in some of these patients, and we attributed failure of treatment to the perforators when in fact it was proximal obstruction. So once we start to unpick those bits and pieces, we may find perforators have less of a role than we thought in certain patients, but there are definitely a cohort where a perforator incompetence is undoubtedly important in ulcer persistence, and we tried to find those groups out in a
Once
better way.
again, you're stressing the need to see the whole picture.
Yes.
Because you are now into an era, you started with the ultrasound, you're in an era when you want to know everything about the anatomy and function of the whole superficial and deep venous system. That opens opportunities to you that our forefathers didn't have.
Yeah, I think imaging undoubtedly has changed our perception of things. So if we're able to easily look at the whole system, and we've got techniques with MRI scan that don't have contrast now, don't have radiation, we can get really good maps of the entire venous system to start putting together these components. Our physiological measures need to be developed, and we know we talk about air plethysmography and other measures which we need to make better. We can try and combine those with better understanding of flow in the venous system and put that together with the anatomical picture, and we can start. I would like to see us refine treatment where we pick the most crucial parts and deal with those in the correct order. We're still a little bit hit and miss, but that is medicine. It has to evolve.
Well, this is fascinating to listen to you. But the majority of venous problems are superficial.
Yes.
And most of the surgeons will operate on superficial varicosities more than anything else. Summarize the current position with the superficial veins, and tell the audience if you think that many superficial venous abnormalities are still being operated upon in a way, and maybe general anesthetic and stripping veins. Is that rife? Is there a huge opportunity of changing to a new method that has not yet been realized, or have most people moved to the endovenous approach?
Well, I think that's again an interesting question, and there's quite clearly regional discrepancies and countrywide discrepancies across Europe when you look at the data.
Why do you think that is?
I think some of it's been cost-driven, some of it's been familiarity with the technique. It's certainly, undoubtedly, endovenous. I trained in an era where we learnt endovenous from the very beginning. So
what do you think is better for the patient then? The knife and an anaesthetic, or an endovenous? If your loved ones, which would you want them to have?
In my opinion, right now, I think there's only one choice, and that's endovenous. But there would be people who have been, James Skerr, for example, would vociferously argue that point. So ultimately, what you're good at, you're going to recommend to people. And I think endovenous has evolved to a point where there's reproducible, defined results that we know we can get sustained good results for patients over time.
So there isn't one way of doing it, but at the same time, the endovenous methods are favoured by the patients who've had it, do you think?
Oh, undoubtedly. I think there's no question that patients, once they get given the option, favour something that's minimally invasive. There's no doubt about that.
So would you say that even the surgeons who are doing the procedures very well by surgical methods would be encouraged to train and have hands-on experience with endovenous and do that?
Well, I think like all things, if you can do a variety of procedures and you know what works best for your patient in your hands, that's what you've got to choose. And I don't think I would ever stipulate to somebody how they should do it. What I would encourage them to do is be broad-minded to the possibilities of new techniques.
So I'll ask you a more tricky question. So if you want your veins done in 45 minutes without an anaesthetic, that would point to endovenous, wouldn't it?
Yes, absolutely. I don't think you can do it any other way.
You couldn't do it any other way. But and there would be more pain involved with surgery, would there?
I think that's true from the trials. That's been demonstrated that pain is worse in surgical approaches.
Which doesn't mean that the way we've done it for years is wrong, but there is a difference. Would it be reasonable at the end of this fabulous interview, I had the pleasure of asking a real expert the state of the art and what we're going to learn at Charing Cross, would it be reasonable to conclude that the patient should know of the options to be able to choose how their veins should be managed?
Absolutely. I think we can't ignore that these days. That's been clear from legal precedent and everything else that we have to deal with. It's a patient's choice, and we need to present them to them in an appropriate fashion.
Stephen Black, thank you for everything you're doing for Charing Cross.
Pleasure.